Well, I'm Dr. Spicher, back for another edition of Coronavirus and Long-Term Care. Here we are again. When I started preparing for this a couple of weeks ago, I thought of titling it Surviving the Winter Surge. But some things have happened, and so it's a little bit more hopeful. And so we're going to say coronavirus and long-term care help is on the way. So today I'd like to talk about sort of where we are in the pandemic. I'd like to give you an update on where we are nationally as well as locally. Talk about some new developments in terms of testing, treatment, and of course the big news, as everybody knows, we're going to spend some time talking about the vaccine and what that might mean. We are truly entering, I think, a dark time, and it's not just because it's that time of the year. It is going to be difficult, I think, for the next few months. More difficult than anything that we've faced so far during this pandemic. So I just encourage you to keep that in mind, that there is going to be some dark times ahead, but I think that there definitely will be improvement on the way. It's always darkest before the dawn, as they say. And unfortunately, we are where it was predicted we might be several months ago with a spike in COVID infections happening in the wintertime. This is a time when the virus spreads more easily. We're indoors more often. People are getting together because of the holidays, family gatherings, and we're all just tired of it. And so maybe if we add some of the political things on top of that yet, in terms of people's thoughts about masks, it all kind of has come together and has made the winter surge really bad. And just how bad? Just this past week, COVID became the leading weekly cause of death in the United States, surpassing heart disease. So far this year, it is the third leading cause of death in the country. And on average right now, about 2 persons die in this country from COVID every minute. So by the time we're done talking here today, an additional 60 people will have likely passed. So it's really pretty bad. In the US, as you can see, this is a graph of kind of the pandemic in terms of the number of cases. You can kind of see where things are going. Note the little dip there for Thanksgiving, where we didn't keep track of the cases quite as easily, but you can see what happened after Thanksgiving. In terms of the deaths, we're approaching the numbers that we saw in the spring, and every indication is that we will likely surpass that rate in the next few weeks. In our state of Pennsylvania, we kind of didn't see the early surge in the spring, and things looked pretty good during the summer. In the middle of the graph there, but you can see what's been happening this fall, and that's what we're all experiencing right now, is the rapid rise in numbers in the community across the state. In our local county, it's pretty much of a straight line until the last month. And you can see how the numbers start to shoot up, really just starting in November. In long-term care in Pennsylvania, you see the little bump in the springtime, and then you see the rapid rise over the last month as well. On an encouraging note, if you look at the death rate, you see that long-term care is doing much better in the fall than we did in the spring. So we know more about the disease, we have some better treatments, I think we have more testing, we have more PPE, so we have, I think, a little better handle on the disease in long-term care than we did in the springtime. I've mentioned this before, that long-term care really is, unfortunately, the perfect storm for this virus. We have a lot of residents that live close together with higher conditions that cause them to be at high risk. Particularly residents with cognitive impairment really can't wear the masks or do the social distancing. And the staff really can't do social distancing and provide care. So all the things that we know to do to reduce our risk of transmitting this disease, we can't do in this setting. So it makes it very difficult to keep this virus out of long-term care, particularly when we're surrounded by a community that has a high positivity rate. And that's what happens. Staff members who don't know they're infected come to work, and that's how it ends up here. And unfortunately, the virus has come to St. Anne's since I talked to you last, over the last month. And our experience so far is that we've had about 15 residents in skilled and assisted living. We've had 2 deaths, and we've had 6 people who have recovered so far. Most everybody has been asymptomatic. Had we not been doing testing, I don't think we would have probably found most of these folks. And so we wouldn't have had the opportunity to quarantine them, keep them away from the general population. And so it's easy to see how quickly and easily this virus can spread in a long-term care setting when so many of the people who have it really don't show symptoms. As you can see, we had 16 staff members tested positive, and 13 of those have recovered. I think there's still a few that are out in quarantine. So if we look at sort of the time frame of when somebody gets in contact with a virus, when they start to have symptoms, when they're infectious, it sort of looks like this. We know that it takes about 4 days after exposure to for the virus to sort of incubate before the person becomes infectious. And the part about this virus that is so difficult is that people can be very infectious, highly infectious, and completely asymptomatic. So on average, for about 2 days before they have symptoms, they're spreading viruses to the people around them. So it looks like during that period before onset of symptoms to about a week after onset of symptoms is when people are the most highly infectious. Turns out that most people who are generally fairly healthy really don't shed many infectious viruses after about 10 days after onset of symptoms. So a fairly short window that way. People who are very immune suppressed or who have very severe cases of COVID will continue to spread infectious viruses for longer periods than that. But that's really the minority of situations. So the really difficult thing about this is that period before onset of infection, where people can be spreading the virus and feel perfectly fine. Again, transmission is droplet. We haven't really learned a lot of new information about this. There were some interesting studies where people looked at who got infected in restaurant settings. And one thing they learned is that if there was a breeze, from the HVAC system, that the air was going in one direction. People that were downstream from that positive person, even though they were further than 6 feet away, got infected just because of the breeze. The 6-foot rule doesn't always apply if you are in a setting like an indoor restaurant. Again, people are most infectious in the first 5 days of symptoms and 2 days before symptoms. So usually there's about a 7-day period where people are most likely to transmit it. We're not quite as worried about people transmitting it through touching things as we were at the beginning of the pandemic. And again, almost all of this happens through our nose and mouth. Some can also happen certainly by touching eyes and face, hence the masks and also the eye shields. Again, this is something a little bit unique to this virus, and this is what makes it so difficult, is the issue of asymptomatic carriage. Up to 50% of people who are positive may never get symptoms. And that certainly has been our experience here at St. Anne's. The majority of the residents who were positive, and actually I think probably the majority of the staff who were positive, had few or very minor symptoms. Sometimes we're catching people before the onset of their symptoms, so we're finding a positive test, and then a day or two later they start to develop symptoms. We call those folks pre-symptomatic. Again, it's the silent spread in the community that makes this so difficult. So what are we doing here to try to reduce the spread? As you all know, everybody is wearing PPE these days. Covering our eyes, covering our faces, wearing gloves, gowns. We have once again, unfortunately, cut down on visitation, trying to limit the number of people coming into the facility. We are moving folks that turn positive to certain halls where they can be cohorted together, where all the positive folks can be, while they wait their allotted period of time until they finish the quarantine and are assumed recovered. We are doing a lot of testing. Given our positivity rate in the county, it's recommended that we test everybody twice a week now. Some wings we're testing 3 and sometimes even 4 times, depending on what's happening recently. So that, I think, has allowed us to try to get a little bit more of a handle on where the virus is spreading and who is positive and who is not positive. These are the CDC recommendations for testing in a long-term care facility, and these recommendations really are based on what's happening in the surrounding community. We are now testing twice a week because the county positivity rate is now around 15%. Last time I talked to you it was 5%. So now we're testing at least twice a week to try to keep ahead of this. In terms of testing, we're all familiar with this. Everybody's getting this done once or twice a week now. The PCR testing really has become the gold standard. It's the most sensitive. It's the one we rely on to find folks early, before they're symptomatic. It detects just little pieces of the viral genetic material. So it's not even intact viruses, it's not even live viruses. So one of the problems with this test is it's almost too sensitive. So it finds things and calls them positive when those people may or may not even be infectious. The antigen testing, the point of care antigen testing, is something that we're doing. We have 2 of these machines now, and we're using this quite a bit. We've, I'm sure, done several hundreds of these tests so far. The advantage of these is that you get your results right away, 15 minutes. This test detects the presence of viral proteins. It's not as sensitive, but it is sensitive when people are most infectious. So when people are shedding the most viruses, when they are the most infectious, that's when this test is more likely to be positive. So in that way, I think it's a helpful test. In addition to being quick and portable, it can show us who are the people who are really at greatest risk to spread the virus around. Compared to the PCR test, it's not going to be, some of those people are going to be positive by PCR, but negative by antigen, just because their viral loads may be lower. So, given all this dark news and depressing tales of woe about what's happening in our community here and around, I think we just need to remember that there is reason for hope. There are things on the horizon that are going to turn this around. We just need to hang in there. In terms of treatment, remdesivir is an antiviral drug that helps limit the replication of the virus, and it is something that can limit the amount of time that people are sick with the virus. I liken this to the way we use Tamiflu for flu treatment. So it limits the amount of time you're sick. It hasn't really been shown to benefit survival a lot. We use it in the hospital when somebody comes in. It's a 5-day course of IV medication. So I think it has some benefit, but it's not a huge game changer. On the other hand, the dexamethasone is a very, very inexpensive old drug. It's a steroid that has been around a long time. It has been shown to really help people, particularly people that are really sick with COVID, people who need oxygen, they've got pneumonia, they've got inflammation in their lungs. It has been shown to improve survival. And so the indication for this medication is for people who require oxygen. So they have COVID, they require oxygen. We start them on this steroid. And this is something that we can do here at St. Anne's. If we have folks that are starting to need oxygen, we can start them on this. It's available as a pill, something that we can easily give here. An old standby kind of treatment that has been used for a lot of different conditions is giving people plasma that is derived from the blood of people who have recovered from COVID. So in their plasma, there are antibodies against COVID, and so we call that convalescent plasma infusions. That has been shown to have some benefit, not a huge benefit, and that is something that is being done locally at our hospitals for treatment of folks with COVID. What's new since I talked to you last is the use of what are called monoclonal antibodies. So these are drugs that are manufactured antibodies against the COVID virus. So rather than infusing plasma from somebody who's recovered, they're able actually to manufacture specific antibody proteins against the COVID virus and then give those drugs to persons who are positive. This is the drug that all the famous people get when they get COVID. This is the drug that our president got when he got sick before it was even FDA approved. So 2 of them have been approved, one from Regeneron and one from Eli Lilly. So far the supplies have been rather limited, and they're quite expensive and not easy to come by. So this may be something that we'll be doing in the future, I don't know. The indication for this actually is for people before they get to the hospital. So the idea is that you give them this drug when they come down with COVID before they get so sick that they have to be in the hospital. So it's actually not approved for hospital use. It's actually approved for outpatient use. So at this point, there's not enough of it around. It was just released. But that may be something that we may be able to use in skilled care setting to try to keep people out of the hospital. The big news, of course, has to do with vaccination. And in my mind, this is really the most important reason for hope, is what has been happening with vaccine development. There's been a whole lot of work on this. Currently, there's 58 vaccines that are in human trials and even more that haven't even gotten to that stage yet. They all work pretty much by the same mechanism, and that is, like other vaccines, they induce our body's immune system to produce antibodies against the virus to prevent us from getting sick. They've been shown to be safer and a more effective way to prevent COVID than getting the virus naturally. We don't know at this point how long the natural immunity lasts after a person gets COVID. The antibodies tend to persist about 3 months or so, and then the levels start to drop. What that means in terms of protecting someone, we don't know. There have been several cases of people having documented second rounds of COVID after recovering from their first one, getting it several months later. That doesn't happen often, but it has been well documented. I think the vaccine really is going to be ultimately the only way that we're going to get out of this pandemic that we're in the midst of right now. So a little bit about some of the viruses that, or some of the vaccines that are currently under development. They all target what's called the spike protein. Those are those little spiky things that you see on the pictures of the coronavirus. Those little spikes that stick out. So all the vaccines, in one way or another, use that spike protein as the target for the development of antibodies. So a protein-based vaccine would be one that people would actually take this spike protein and inject that. Our body would recognize that as a foreign protein, build up antibodies to it, and that would be the way that vaccine would work. There are genetic vaccines where people take the DNA for the spike protein. They put that inside a viral shell, and they inject that into the individual, and the virus then injects the genetic material for the spike protein, and then the body actually makes the spike protein. So those are two types of vaccines that are still under development. They're a little further away from FDA development. The third one is really the one that has been approved and the one that we're going to be hearing the most about in the near future, and those are called the mRNA vaccines. RNA is the genetic code that viruses use to make proteins. And so the way these vaccines work is they take that little genetic code, that RNA that codes for the spike protein, and they inject that RNA, and that's the vaccine, is the RNA. Our body cells take that RNA, they recognize it as a genetic code, and they make spike proteins. And then our body's immune system, again, recognizes this spike protein as being something that is foreign, and that's how the vaccines work. So again, a little more about the mRNA vaccines, because this is what we're going to be dealing with for the next several months. They can't give you COVID because it's not a virus. It's just a little snippet of RNA. They don't have live viruses. They're not killed viruses. There's really no virus involved. This technology of using the mRNA is something that has been around for quite a while, actually. It's the first time it's used to make vaccines, but it has been used in cancer treatment for quite a number of years. So far, the early results have been quite exciting. It's been safe, it's been reasonably well tolerated, and it's been very effective. So far, these vaccines require 2 doses to give the most benefit. So just an overview about how those vaccines are made. Again, you take that little mRNA, and that's manufactured. People can make little snippets of genetic material now in the laboratory. So that's the little mRNA sequence, or the little snippet of viral gene. And they coat it in a little bubble of oil. So a little droplet of oil, if you will, very, very tiny, with the RNA in the middle. And then that's what the vaccine is. So the vaccine is a bottle of little tiny droplets containing little snippets of RNA. That's what gets injected. And then those little droplets get into the muscle cells. The RNA is released. The muscle cells make the proteins. The immune system recognizes those proteins. So I'll walk you through that just one more time. Again, this is what the virus looks like. The little spike proteins are those little red things that are sticking on the outside. There is the part of the genetic code of that virus codes for that spike protein. That's that little red snippet there that has the arrow on it. So we take that little piece of RNA and we coat it in a lipid, an oil. And the reason we do that is that protects it from the body when it first enters, and it allows it to enter the cell. So if you just injected the RNA by itself, it would just get destroyed by the body, and it wouldn't get inside the cell where it's needed. So as you can see, the little particles attach to the muscle cell after they're injected into your arm. And there are little parts of our cells that make proteins when they recognize the genetic code. In this case, when they get the genetic code for the spike protein from the vaccine, they start making spike proteins. And our immune system then recognizes these foreign proteins that are sticking on the outside of muscle cells, and that raises an alarm in our immune system. And it turns on cells that make antibodies that match specifically with those spike proteins. So this is how our immune system works. This is what happens every time our body encounters something foreign, a cold virus or a bacteria. This is how our immune systems protect us from disease. So once we have these antibodies floating around, if a coronavirus does get into our body, these antibodies recognize it and immediately surround it. They latch onto the spike proteins, and then that virus particle can't infect the cell and make us sick. As I'm sure you're all aware, the first vaccine developed by Pfizer was approved this past week on the 11th, and people are starting to get vaccinated already. I think some of the folks at LGH are going to be vaccinated tomorrow, I heard. So just a little bit about the trial that they used to approve this vaccine. So they started with about 44,000 people in 6 countries. They divided them in half. Half of them got a placebo, half of them got the vaccine. The people who were getting the vaccine and the people who were giving the vaccine had no idea who was who. So they did that, and then they waited. And they waited until people got sick from COVID, essentially, is what they did. So as you can see in the placebo side, the half that got the placebo, 162 of those 22,000 people came down with symptomatic COVID. fairly mild, but people that had symptoms. These were not just people that were tested and positive. These were not asymptomatic people. These were mildly symptomatic people. So 162 people who got the placebo got it. Only 8 people who were vaccinated got it. In terms of severe disease that required hospitalization, oxygen, medication, there were 9 people in the placebo group and only 1 in the vaccine group. So this is a very effective vaccine, and this is very different than, for example, the flu vaccine. You know, the flu vaccine, if it has a 50% protective effectiveness, we're happy with that. This would be similar to what we would expect from, say, a measles vaccine or a smallpox vaccine. So a very effective vaccine and very impressive. The Moderna vaccine, which is another mRNA vaccine, likely will be approved this week. It's interesting that their trial had pretty similar results. Again, about 30,000 people split into 2 groups. 185 people in the placebo group got sick. 11 people in the vaccine group got sick. 30 people in the placebo group had severe disease, and none in the vaccine group in that trial had severe disease. So really a pretty dramatic effectiveness. And very similar. It's interesting that they were both about 95% effective, keeping people from getting sick. The good news, I think, is that it works really well in seniors. One of the problems with vaccines in seniors is sometimes they don't work as well because their immune systems don't get stimulated as well because they don't work as well. So they don't mount as much of an antibody response. Both of these vaccines were tested in seniors, and both of them worked really pretty well. In the Moderna vaccine, they had 7,500 folks over the age of 65, and they had an 87% effective rate. In the Pfizer trial, they had 18,000 people that were between the ages of 56 and 85, and they had a 94% effective rate. So unlike some other vaccines, particularly flu, where we find that the effectiveness drops off in the elderly, this vaccine seems to work just as well in the elderly as it does in younger, healthier people. The vaccine, so as a result of this, the CDC is recommending that staff and residents of long-term care facilities be among the first people that get the vaccine, along with first-line healthcare workers. The vaccine is a bit of a challenge. It needs to be kept very cold. In order for those little lipid particles to be stable, they have to be very cold, and they don't last very long. They're not very stable once they're thawed out. So it has to be kept very cold, and then it has to be thawed out. And once it's diluted, it has to be given, I think, within 5 hours before it stops being effective. So it is a challenge to give. So in this country, the way they have decided to roll it out is through CVS and Walgreens, and they're going to be the providers and the administrators of the vaccine to long-term care. So details are still being worked out exactly how and when, but I think before the end of the year, even here in Lancaster County, there will be some long-term care residents who will be vaccinated by either CVS or Walgreens. So we haven't received dates as of yet, but I expect that we will be hearing soon. What about side effects? So the good news is that there were no serious side effects where people became gravely ill. A lot of people got some side effects, more than you would expect with a flu shot. And these were things that you might expect from what you would say is a flu-like illness. So feeling tired, maybe having some headaches, muscle aches, chills, sometimes fever, injection site pain, muscle pain. Those of you who've had a Shingrix vaccine, A lot of people say it was similar to that. So that is something I often warn my patients at the office. I say, take some Tylenol after you get your Shingrix. Expect that you're going to have pain at the injection site. You may have some fever. For all these folks, the symptoms went away after 1 to 2 days. Usually after 1, but certainly by 2 days, all the symptoms were gone. This amount of side effect is normal. This means our immune systems are responding. It is a good sign. It means that we are mounting antibodies. So this is expected. And so we just need to remember that you have to put up with 24 to 48 hours of some side effects that should respond to Tylenol in order to get a good immune response from these vaccines. The experience so far in Britain, where they started vaccinating last week, was that there were some allergic reactions in people who had a history of anaphylaxis. I think there were 2 so far that I've heard of, where they actually needed to give those folks epinephrine because of the allergic reaction that they had. So this happens with other vaccines as well, and I don't think is entirely unexpected, but what is being recommended is that people be observed for about 15 minutes or so afterwards when they receive the vaccine. So in case there is some kind of allergic reaction, they can receive treatment for that. So there's some things we don't know yet about the vaccine. We don't know for sure how long that 95% efficacy will last. The hope is that this is going to be a long-lasting. It may turn out that it's sort of like the flu shot, and every year we're going to need to get COVID shots. I don't know. I think most experts would say that it's probably going to be longer lasting than the flu shot protection is, but we won't know that until we have more time. The people who are in the trial are probably at about 6 months now in terms of people who got their vaccine, and they still have robust antibody levels, and so that's encouraging. But again, that's all we know is where those people were who were in the trial. So it will take probably years until we know how long this protection will last. The other thing we don't know for sure is whether it will prevent us from transmitting the virus to someone else. We know that it protects us from getting COVID. It protects us from getting sick, but we don't know with certainty whether it protects us or prevents us from transmitting it to others. So again, more research is going to need to be done on that account. So, as you might expect, there's a lot of talk about the vaccine and lots of concerns about its safety and lots of conspiracy things that have surfaced about the vaccine. So I just put a few out here, and I'm sure there are more, but this vaccine is not a live virus. It doesn't actually have any virus in it. So it really can't cause us to get COVID. It is not, the side effects of this really are not worse than getting COVID. If we've had COVID already, we still should be vaccinated because it's been shown that the antibody levels induced by the vaccine are much greater than what you receive with the illness. And we don't know, as I mentioned earlier, we really don't know how protective getting the disease naturally is against preventing it from happening again. So it looks like the vaccine is a much safer and much more effective way of protecting us from getting COVID in the future. There were no fetal cells involved in developing or manufacturing the vaccine. There are no microchips involved. And the side effects, other than those I mentioned, really in those 2 trials of about 70,000 people, we didn't see severe life-threatening kinds of side effects. So until until a majority of the population has been vaccinated, we're kind of stuck with doing what we've been doing. Keeping our masks on, doing all the things that we know work to keep us from transmitting the virus. Again, masks have been shown to be probably the most effective way of decreasing transmission. They protect us as well as the people around us. We know that they work really well in healthcare settings from the research that's been done. In terms of what we're doing to reduce our risk of COVID transmission at St. Anne's, as you all know, we're all wearing PPE these days, covering our eyes and our faces, wearing gowns and gloves. We're doing hand sanitation, social distancing, of course. This is the difficult thing, and the toll that it takes on our residents and their families, just that separation and that isolation, which makes this pandemic all the more difficult to bear. We know that the risk to our residents in long-term care really is a mirror and reflects what's happening in our community. So just like we saw, we were doing pretty well here at St. Anne's until the community rates started to skyrocket. And so when we're surrounded by a high rate of positivity and lots of asymptomatic COVID in the community, it is almost impossible to keep it out. So in some ways, we're at the mercy of what's happening in the community around us. We are also dependent on the judgment and the behavior of the staff in terms of what they do when they're not at work. So again, a reminder that what you do at home and what you do outside of work and the decisions that you make do have bearing on what happens here at St. Anne's in terms of whether you unfortunately would bring the virus to work with you. Again, anything that we can do outdoors is going to be safer than indoors, and that gets more difficult as the weather gets colder. So a word about Christmas. Needless to say, this Christmas is probably going to be unlike any that we have been through. And I understand that, you know, we're all tired and we want to be together with our friends and relatives and do the things that we normally do over Christmas, but I would encourage us not to let down our guard and risk exposure during the Christmas holidays. I would say a good rule of thumb is not to get together with people indoors that you don't already live with. There's an interesting calculator tool that I found from the Georgia Tech that looks at the local community COVID rate, and it takes into account the size of the group that you get together with, and it tells you what the percent chance of someone in that group having COVID is. So currently in Lancaster County, a group of 10 people getting together, there's a 30% chance that one of them has COVID. It's about a 50% chance if that group is a 20-person group. So that is just, those are just the statistics, those are the chances that we're taking when we're getting together indoors with friends and family. So I would just encourage us to try to stay the course and try to bear with this for a few more months until hopefully the vaccine will be more widely distributed and the risk and the positivity rates go down. I just want to recognize the work that everybody is doing. It is hard work. It's not easy to wear masks and face shields and be worried about, you know, did I do this right? Did I sanitize right? Did I put my gown on right? It's stressful. It's hard work. And I think that the staff here at St. Anne's really deserves recognition. Everyone from housekeeping to maintenance to dietary to the clinical staff, the administrative staff. Everybody has really stepped up and pitched in, and I know that it has been scary, but I think you're all doing a wonderful job. And I would encourage you to keep up the good work. One of my friends is a medical director here in Lancaster who is on a task force through the Department of Health that goes out to long-term care facilities whenever there are outbreaks. And so he's been traveling all throughout southeastern part of the state, helping to advise communities who have COVID outbreaks. And I called him up the other day and told him a little bit about what we were experiencing and said, you know, what can we do differently? Is there something else? You know, what are we doing wrong? Why is this happening? And what he said was, what we have experienced so far shows that we're really doing a good job. And that what is typically seen is week 1, there's 1 positive case. Week 2, there's 3 positive cases. Week 3, there's 10 positive cases. And it goes from there. And so my hope is that we're going to see the numbers here, you know, go to 0. We've had, every week we've had 1 or 2 that have popped up, but we haven't seen the explosion in the numbers, and I think that's a testament to the work that you all are doing, and I would encourage you to keep it up. We will get through this, and there is a light at the end of this tunnel, so I'll be happy to answer questions later then. Okay?